COVID-19 pandemic has crossed the one-year mark. Cases, hospitalizations, and deaths continue to trend downward. But even with that progress, we cannot let our guard down. Using data to inform the response to the COVID-19 pandemic can help improve COVID-19 testing and vaccinations, in turn reducing illnesses, hospitalizations, and deaths. COVID Data Tracker is CDC's easy-to-use home for COVID-19 data. It offers easy-to-interpret visualizations, such as interactive maps and graphs of vaccinations, cases, hospitalizations, and more. Grouping data by category makes it easier to find the data you need. CDC is helping people across the country get vaccinated while tracking the progress of the National Vaccination Program and sharing that data publicly. There has been significant progress in vaccination. While COVID-19 vaccinations are increasing across the country, Black, Hispanic, Latino, Asian, and tribal communities are currently getting COVID-19 vaccines at lower rates than white communities. By using data to drive vaccine implementation and the response to the COVID-19 pandemic, cases, hospitalizations, and deaths could continue to trend downward.
Thank you, and welcome to today's session of our Drive to Data Vaccination Implementation. My name is Dr. Oscar Allen. I'm the Chief Program Officer at the National Association of County and City Health Officials, or NACHO for short. It is my pleasure to be one of the partners with our colleagues here at CDC in this particular forum. Today's conversation, as we think about the data to drive vaccine implementation, we're very happy that this town hall focuses on the use of technology to manage COVID-19 vaccination. This moment in time is a chance for us to be the change that we're supposed to be. And I'm very excited for the sessions which will explore opportunities and challenges in our own use of data and technology to manage implementation strategies for COVID-19 vaccination. Through this conversation, we will contextualize the best practice approaches and provide current examples of incorporating technology to address COVID-19 vaccinations and examine how we can center equity when defining these strategies for the benefit of our communities. Yet, no matter the size and configuration of our departments or agencies, I believe that there are core fundamental lessons that we can all learn from each other and apply to our own settings. Our global to local response efforts provides us with this opportunity and a framework to develop and enhance our partnerships. And as we work to better connect through those relationships and the agencies or sectors that we represent, we will learn from each other and improve. This town hall sessions provides a perfect example of this. And these 3 days as a whole provides an ideal forum for all of us to build upon those successes and enhance partnerships along the realm of data-driven solutions and communicate better through the sharing of information amongst us, public health authorities, and our private sector partners. But before I begin, we do have a poll question that we need to ask and provide to our audience members at this time. Make sure it's up and running. So, poll question is, what is the main reason you decided to attend this practitioner town hall session? Is it that I want to hear about promising practices related to data management for COVID-19 vaccine implementation? I want to increase my understanding of public-private partnerships to enhance and integrate IT systems. I'd like to learn new ways to enhance data quality and timeliness. We'll pause for you to answer the additional questions. Thank you. The majority of the responses seem to indicate that they want to hear about promising practices. And with that, I jump right into our esteemed panel of colleagues that we have today. First up is Dr. Joseph Cantor. He is the State Health Officer at the Louisiana Department of Health. Dr. Cantor, what are your key successes in using immunization information systems to manage vaccine implementation? And what enhancements have you made to the systems to collect additional data to better inform decision-making?
Hey, thanks, Oscar. Thanks for the question. To my fellow panelists, thanks everyone for joining. It's really a pleasure to be here. I do want to just sincerely thank everyone that works for the CDC. Listen, this has been just the most challenging of times. There's going to be a lot written about what you have been through and what you were able to do. And it really is remarkable. So for folks that work at the CDC, what you do is appreciated. I mean, this forum, of course, included, but everything you've done in the past 12 months has been so appreciated. So please know that we all really appreciate what you're doing. I will say, I'm not ready to count any chicks before they're hatched on this. And we're still deep into a pandemic. So, I'm looking ahead. I'm not ready to call anything a success or a failure yet. For Louisiana, we've got about 13% of our state's population at least started the vaccine series. That grows every day, obviously. That's where our eyes are right now. And that's what I think we're focusing on. It's been interesting with the data. The data has been messy, and there's no question about that. It's been messy across the country. It's messy in every state. And part of that is because things have had to happen so quickly. With the vaccine rollout like this, it's not like a product launch where you can delay a couple of weeks to get your ducks in a row for it. So things are catching up. And the other thing, and I think folks that work in the health department will understand this, people have been going nonstop for 12 months now. So there's been operational challenges, and people are tired and taxed. And so I think when you have new data challenges that come up, it's that much more challenging because it's another emergency on top of another one on top of another one. I will say, I think one of the things that we've been able to do decently well in Louisiana over the past couple of weeks is overcome some of the data quality issues around demographics. Much like the rest of the country, we initially had an exorbitantly high number of unknown or other racial categories. For example, with our vaccine demographic data, we had 56% on our first couple passes. Nationally, it was about 49%. And the challenges were multifactorial. We had data coming in, entered in by end users, by vaccine providers, that wasn't complete. We had data connection issues with the big healthcare systems that have automated feeds with our state immunization database. We had our own server processes, and then a number of other issues. So it really was multifactorial. One of the strategies that we employed to get to where we are now, which is we're down to about 10.5% of unknown or other, which is still needs to get better, but significantly better than where we were, is we were able to cross-reference with a number of existing databases that the state has access to: Office of Motor Vehicles, Medicaid, hospital admission, discharge, transfer summaries, and a couple of hospital systems actually as well. The reason why we were able to make those reconciliations happen, looking from the perspective now, is because we had forged good partnerships with other agencies earlier on through this. We had forged a good partnership through other means, through the Office of Motor Vehicles, and we were able to leverage that partnership to cross-reference our vaccine database with existing databases to clean up some of the racial data. So I think that sets us up better to go forwards. I mean, we all know that there are very stark racial disparities right now in who is getting vaccinated. We're challenged by our ability to definitively articulate that because the data isn't there. But you have to be honest about what the challenges are. You can't gloss over that you don't have data on, let's say, 50% of the people. You have to put it front and center. So I think we're able to do that. I think a lot of states are able to do that now. And going forward, I think that gets a lot better. Really, you cannot be adequately addressing equity in vaccine distribution unless you can accurately describe it. And I think that's the challenge of the day right now, Oscar.
Thank you so much, Dr. Cantor. Moving on to our other colleague on the panel today is Sarkis Pogosian. Sarkis is the analytics director for communicable diseases and the immunization team out of Seattle King County's Public Health Department. Sargonis, what metrics and decision tools are you using to ensure equitable vaccine implementation? Specifically, how are you defining equity and how do you get data with the help of partners to support decisions and track implementation?
Hi, everyone. I also want to echo Dr. Cantor's in terms of really grateful for CDC and for many of our state and local health departments that have helped us throughout the year. It's been definitely a challenging year, but we all are really grateful to learn from each other and grateful to be part of this panel and hear about what other places have had successes and challenges with. That definitely echo what we're seeing in King County. It's a large question. I wanted to kind of just emphasize a couple of things that have helped us in terms of grounding us in what we should be looking at and how we should be making decisions. We are primarily looking at where, and we've started over the summer once there was some promise in vaccine rollout towards the end of last year. We had been using a lot of our COVID data based on incidence by BIPOC populations, by geography, and by age groups to narrow in on geographies, both large and down to the neighborhood level in terms of where we had seen high incidence rates, high hospitality, hospitalization rates, and also high mortality. One of the things that we had really focusing on was for King County, adults above the age of 65 represented only 11%, 49% of our hospitalizations and 85% of our deaths. And with some of those metrics, we had also looked at how that differed across the county. And once we were able to start with vaccine distribution, we were looking at whether distribution sites were also located in areas that would serve the populations best needed and most vulnerable to further COVID infections, particularly with severe infections among elder populations or individuals living in long-term care settings, which were part of our phase 1A eligibility criteria. So once we looked at our data, we identified some areas that had the highest incidence rates and highest mortality rates, particularly among older adults, and were areas that were primarily communities of color, that did not have adequate distribution sites or had distribution sites that we were not able to do high volume tests. I have high volume vaccine distribution. So one of our decisions early on was to implement high volume vaccine sites in the areas that we had identified as being the largest gaps that we had identified in the county. And throughout the pandemic, we've learned a lot of things that have helped guide with the rollout of distribution. It's not to say that the distribution has been perfect. There's certainly lots of challenges that continue and lots of things for us to still fix and better address. But one of the ways that we've been able to use our data and work with our partners in the county and improve the way that we engage with the community members, stakeholders across the county has been with weekly, and now it's shifted to bi-weekly, but for now, a full year since we've been in pandemic, or since we've been in outbreak response since January, where our neighboring county had the first case. And I also just want to mention that we're coming across the first that was reported nationally, and it was here in King County. And then the first outbreak that was reported nationally, which was also here in King County at a long-term care facility. And it now marks over a year that we've been in this outbreak response. And through that year, we've developed lots of relationships with community stakeholders, which include both large corporations that have very large workforces, various different types here in King County, as well as faith-based organizations, community clinics that serve primarily BIPOC communities, and other major organizations, including schools. And we've been using our data to inform them of what's happening, engaging where would be best pop-up sites, best clinics, and why some of the metrics that we're tracking may not be reaching the targets that we were trying to get them to reach, and continuously adjusting our methodologies on distribution and implementation. I have a lot more to say, but I think in terms of time, that's some of the highlights.
Thank you for those highlights. It's very impactful and helpful, especially as we think of how robust and constantly moving these decision-making points are. Allow me to go to my next presenter and town hall panelist. Dr. LaQuanda Nesbitt is the director of the District of Columbia, our nation's capital, Department of Public Health, Department of Health. Dr. Nesbitt, what are your successes in implementing registration portals and using registration data to inform communication and outreach to communities and to potentially adjust distribution plans?
Well, thank you so much for the question, Oscar. And also, I'm glad to be here with colleagues and having a discussion about vaccine implementation and how we're using data and technology to support our efforts, and to the CDC for hosting this week's events and activities, because so much of what we're doing is, some people will say, building the train tracks while the train is moving, or building the airplane while it's flying. But we've also, this use of technology and the robust use of data to drive our decision-making and our response to this pandemic is based off of what we learned from H1N1, which was not very long ago. Including the way that we have individuals scheduling appointments as opposed to waiting in line and on queue for appointments at mass vaccination sites, possibly to be told that there was no more supply, and also to be able to have more of an idea as to where vaccine resources were around the country and in their own neighborhoods. It also gives us a tremendous opportunity to do a better job of having data at our fingertips to look through the lens of equity, which so many of our state and local health agencies have been doing for quite some time in order to better manage population health. And in order to do that, you need to have data that is centralized or in some repository, as opposed to on paper documents somewhere that never make it into a database. And so we have been able to implement in the District of Columbia, in addition to having updated immunization information systems that Dr. Cantor spoke about, a centralized process for the registration for vaccination appointments. And many states and jurisdictions have done this. The CDC had created a product. It was in the playbook for all of us to use. But we've been looking at how our system can ensure that the residents who live in neighborhoods, and our geopolitical construct is wards. We talk about wards a lot, separate from counties. But to ensure that the residents who are living in those neighborhoods and wards that have the highest burden, disease burden for COVID-19, both from a morbidity and a mortality perspective, are the ones who are getting access to COVID-19 vaccination. And so we, of course, like most jurisdictions, place the vaccines in terms of clinics with provider agreements, ensuring that vaccines were equitably distributed from that perspective. But we know that people with means and influence and affluence will drive hours to get a vaccine if they can secure the appointment. And so how we use the technology and structure the technology to ensure that individuals in those neighborhoods or wards with the highest disease burden can get those appointments became critically important. We began to use our technology system very early on with our healthcare workers who were not affiliated with large hospitals and health systems being vaccinated in closed pods, and having them be scheduled in our local retail pharmacy initiative that began in early December. When we began vaccinating individuals 65 and older, which was our chronic disease population that we launched in mid-January, the first week that our vaccine registration and appointment system went live to what was considered to be a broader general public group, 70% of appointments were claimed by residents in our wards, 3 wards that had the lower disease burden, 70%. So we shifted the following time that we had appointments available to ensure that residents in the highest disease burden communities, we began to call them our priority zip codes and priority neighborhoods. So they would be given a 24 to 48 hours advanced ability to register and schedule for appointments when vaccine became available over those neighborhoods that had a lower disease burden. And we make adjustments to what the priority zip codes are in our registration and appointment scheduling system. Now, as we continue to make user-friendly updates to that registration system, we can make those updates with continuing to apply an equity lens that would allow us to ensure that not only vaccination clinical locations are in neighborhoods with the highest disease burden or the highest social vulnerability index, but that the appointments are actually accessible to those individuals. So that's been just a key way that we look at that data. We look at it on a weekly basis to ensure that, again, who's getting an appointment, how appointments are being scheduled through the use of technology really does become useful. And it does have a companion piece. I'm sure we'll get to that in the discussion. We think that some of the commentary about digital divides, there's a difference between having access to broadband versus having access to internet tools and solutions. And many of our residents have access to smartphones. And so much of our technology, all of it, in fact, is accessible via a smartphone. But we still have people who don't want to schedule anything online. So we have a call center that's available as well. And we're mindful on a weekly basis to have a select number of our vaccination appointments dedicated to our call center for individuals who do not want to use technology, but all of the data ends up in the same place. So I look forward to a more robust discussion. Thank you.
Thank you so much for that, Dr. Nesbitt. It definitely, speaks to that digital divide and also how to develop these hybrid systems that both include technology as well as recognize that there are elements that doesn't necessarily interface with technology well. Which brings us to our last speaker on our panel discussion here in our town hall, Jim Daniel, who is the lead state and local public health in the division of Amazon Web Services. Jim, please speak to the national perspective and current best or promising practices in the public-private partnership realm that are used to build more robust data infrastructure and provide technology solutions that and support to jurisdictions.
Thank you so much. I'm honored to be here, and thank you to the CDC and NHO for this. And I'm really honored to be on the panel with our state and local health departments who do such an amazing job. I feel so lucky to be a resident of DC, and things are just run so well here. And if anyone didn't happen to notice the link that was dropped for the DC data, it's something I check every day, and I encourage everyone to look at it. It's really amazing. So I just wanted to kick off the conversation really talking about how the state and jurisdictional immunization information systems are so critical to this response. Ultimately, that is where the data resides for the vaccines that are administered. And it's really important for us to think about how those systems are going to be scaling. During the earlier parts of the pandemic, we actually saw some systems fail that were critical. During the earlier parts with testing, electronic lab reporting systems, and the disease management systems where that data flowed into were critical in the earlier parts of the response. And those systems, were often built 15, 20 years ago and had not been built to really scale to the volume that we're seeing with COVID vaccinations. And because of that, we saw a lot of failures. And I think it's really important to help our state and jurisdictional IIS start figuring out how they're going to scale their systems so that they can support the huge number of the huge amount of data that is going to start coming in, especially as we start moving into phase 2 of the vaccine response. Not only do we have to think about the reporting of vaccines coming in, but a lot of these systems are built to support what we call a query response system as well, so that a provider, as they're administering a second dose, can actually query the IIS and make sure that the first dose was the same vaccine that's being given the second time and that the time frame is correct. And those interfaces can potentially fail if we don't scale these products correctly. And a great way to really make sure that these IS can scale and can handle the volume is to move them to the cloud. We saw that both with electronic lab reporting and disease surveillance as well, that moving the infrastructure to the cloud allows those systems to scale. And we have a lot of states that have actually already done this. One of the major vendors for immunization information systems, STC, has actually already moved all of their clients to the cloud. And they're now in a much better place to be able to scale. And I want to point out that it's not just the vaccine administration and the query response where we need to be ready to scale. A lot of people are going to want to start having access to this data in near real time. You know, payers, employers, schools, they're all going to start to want to build interfaces to our immunization information systems to verify vaccination status. And we really need to be prepared for that. And migrating to the cloud, I think, is really one of the best ways to prepare for that. And also migrating to the cloud helps with the built-in privacy and security models that are there. The other really exciting public-private partnership that I've seen start to develop is some of the companies like Docket and STC that are working to make sure that consumers have direct access to the data. I think it's really important to make sure that the consumer has that digital access to their data and they're not just relying on an index card. So I think that's a really exciting public-private partnership that's going on right now as well. And then finally, looking towards the future, I think, you know, the public-private partnerships really need to take a step back and document our lessons learned and start to think about what does a modern IIS really look like? What do we wish we would have had in place prior to COVID response? And really start working together to start building those scalable systems that have all of the functions that we wished had been there already. So thank you, Dr. Allen. I'll stop there.
Thank you so much, Jim. I think our panelists have really provided a very robust look at the wide range of conversations that we plan to have today. But first, because it is an immersive experience, I'm going to turn back to our members of the audience for our second poll. And the question is as follows. What has been your biggest challenge in the establishment and operation of the COVID-19 vaccine program? Solutions, or I should say answers, are leveraging immunization information systems and other external systems, support and provider functionality and internet access, scaling immunization gateway solutions, connections, and interoperability for federal reporting, addressing legal and regulatory challenges related to information sharing, or supporting data dashboards for public reporting. We'll give you a few moments for you to give us your responses. And as we see, most of the respondents have indicated leveraging immunization information systems and other external systems. Thank you very much for your participation. So here's where we get into a little bit of the weeds. And we're going to ask our panelists a series of questions. Some of them have been submitted by your audience members, you as well. So let's just jump into it. Please describe examples of how data management and reporting systems have been used and vetted to ensure transparency and accountability in vaccine distribution and to address distribution plans as needed.
Sure, I'll go ahead and jump in, Oscar. Listen, you have to let people know where a vaccine is going. You have to let people know who is being vaccinated, and you have to let people know what the thought process is of how those decisions are made. This is, a public good, a public interest, and that type of transparency is essential. I think it took, and I mean, certainly on behalf of Louisiana, but I know a lot of other states are in that boat too. It took a few weeks to just get the data systems to the place where that type of granular data is possible, because things move so quickly. But once the capability is there, you have to have transparency in where vaccine is going and who is being administered. I'll say one other thing on this. All of us have some shortcoming with our data. I don't think anyone's data system from the CDC on down is exactly where they want it or it needs to be. Put those shortcomings front and center. Don't hide what the shortcomings are, because if you hide it, then it becomes much more difficult to muster the resources to fix it. And I mean, the one example that sticks in my mind is the demographic data, specifically the racial and ethnic demographic data. And you see a lot of stats out there that take out the unknown and make it seem like it's not even there. And I don't want to be kicked off of the panel, but the CDC does this too. I mean, when you look at nationwide numbers, right now about 49%, or at least it was as of a couple of weeks ago, nationwide, we don't know. The data's not there. Put that in there. Don't take that out of the graphic, because if you hide it, you really make it more challenging to go address it, and it really does need to be addressed.
I couldn't agree with Dr. Cantor more. And one of the, we were probably in the middle of the states or jurisdictions who started releasing our race and ethnicity data. And my concern about releasing it had nothing to do with transparency. I think you heard Jim talk about this overwhelming amount of data we release on a daily basis. So we're big on sharing data and information, but the disproportionate amount of individuals, not just unknown, but documented as other, was such a high proportion of individuals, disproportionate from any other health service or program that we offer, that were being captured as other, that we just did not feel that the data was reliable. And we were going to get a lot of pressure to pivot in terms of our program and our approach based on this data that was woefully incomplete and inaccurate. And we still get that about our missing data for ethnicity is still probably around 70%. And we've begun to do some of those things that Dr. Cantor has mentioned, not as fast as the clip as he has. I can't wait to get back and tell my team Louisiana is down to 10%. But we've started to do some of those things, but we get a lot of push that says, the Latinx population is not being reached. So what we end up doing as a result of that is, unfortunately, so many of us have jurisdictions that are highly segregated from a race and ethnicity perspective, is using geography as a proxy to be able to talk about whether or not we are effectively penetrating certain communities, because that data is simply missing until we can clean it up using some of those things that Dr. Cantor has mentioned. I do believe that we could probably have more transparency around who the actual providers are, instead of just these broad maps around where vaccines are going, and at the jurisdiction level, both the state and local level. Outside of these sort of trying to use the vaccine finder, which I could imagine is probably extremely frustrating for a member of the general public to use that tool, and there's often no vaccine there. But just giving people some insight into the diversity of providers that have been deployed, and why we're having some of the challenges that we're having. You're talking about health systems that have very sophisticated technology tools, comprehensive electronic health records, who have been working on collecting better social demographic data on the people they serve, being vaccine providers. And then we're talking about other providers, retail pharmacy providers, who have not collected the same amount of robust data, used immunization information systems and interface with local health departments, as well as community-based organizations that are coming on board doing pop-up mobile sites that are meeting the minimum requirements for technology. So I think people having a bit of an understanding as to why some of the data quality is disparate based on the types of providers who are being used, and rightfully so, because they have different abilities to engage people into the vaccination process, which is absolutely what we need right now if we're going to balance equity and efficiency in vaccine administration.
I wanted to add a couple of things. I very much agree with what both panels said about the reporting and transparency, as well as the missingness of data has been I'm glad to hear what other people are experiencing, because it helps put things in perspective. And I think it'll also be surprising to the team to hear how well people have been able to get that number so low. I think we're at about 20% missing or other, but other is our biggest category. And it's been extremely frustrating on trying to understand where that's going. One of the ways that we are trying to work with our reporting to help fix or address these issues is we're doing provider-based reports that we're sharing with providers, not publicly, just because we're trying to avoid any sort of public shaming, but a little bit more of a nudge in terms of trying to figure out, give them transparency in terms of what we're seeing from the data that they're entering, and hoping that they could provide us with a more specific detail of why they're seeing those numbers, because every place has a very unique and individual reason for why the data is being marked as other or missing or unknown. Some of it is very technological in terms of they already have bidirectional feeds from their ELR or their EMRs and then IIS, and they're not updating. Some places are just not updating race ethnicity data as they're entering the COVID vaccine. So whatever was in there from, whenever the record was created is what it's there. And some places just, maybe haven't been nudged enough yet. One of the other things I wanted to mention about this question, talking about data management, because, from my standpoint, it's been one of the largest challenges throughout this entire year. 2020 on has been data management. We are, I think Jim mentioned it early on, we're failing systems. We've had systems fail, and every system has failed at one point or another. And it's been really rapid turnarounds, and really grateful to everyone that we've worked with, including private partners and so many people within public health that have pushed through. But data management is a real struggle right now, because currently we have about 500,000 doses. Each of those are individual records, and we're not even open to higher populations being eligible for vaccines. Once we reach levels that are, hopefully tens of thousands of folks are getting vaccinated each day, that adds a lot of pressure to a system that is certainly not built for this kind of thing. And we saw this in testing so quickly, where, as I said earlier, when we were in the very beginning of our outbreak response in February, we were getting single test results a day, and it was very easy we were getting faxes, and, being able to do manual entry. And we had our first confirmed outbreak February 28th, 29th. And by March 2nd, we had, hundreds and thousands of test results coming, or not test results, but hundreds of test results coming in. And it already broke that fax system where it was taking 24 hours for faxes to come in. And by mid-March, our electronic lab reporting system failed. And, that was 1,000 or so records a day. When we look at things now, we've been able to sustain up to 50,000 records a day now, but it's still pushing the limits each day. So when we look at vaccine, we're certainly going to be facing similar challenges with vaccination nationally, but certainly in our local level, where hopefully we get as many people as possible getting vaccinated. But if the individuals are not able to enter data into the system because of how long it takes for the system to load, or it doesn't load because so many people are trying to ping it, or people are not able to access that data and make correct evaluation of where that program is going, that's going to cause great ripple effects throughout our entire program and our response.
Those are some really good points. I think all of our health agencies have been, the victim of systematic defunding over the years, decades and decades worth. So at the beginning stages of this pandemic, we had data teams. We were working with what we had, and it was trying to drive a late model sedan, 1,000 miles down the highway. And I think we all benefited from really committed public servants on our health departments who managed to do that and found really creative ways to do that. One of the things that I'm very thankful for is that the Biden administration has taken a clear direction that with the increased financial resources coming down to states and other jurisdictions related to COVID and the vaccine, that they're really having an eye towards meeting the need currently and also building a platform that will serve in time to come. That's been a clear articulated direction of what the funding stipulations are. I think that's the right move. So I'm very thankful about that.
You all raise an interesting point, and I think it's intriguing on two fronts. One is that of the infrastructure, and I think several colleagues I've known have said in a couple instances, the public health industry, the public health community is probably single-handedly keeping the fax industry alive, given contextually the fact that we're still using faxes to receive health information. But you also raise another key point around this issue on data quality in demographic information, especially with this resounding topic around the others and the designation as such. Just today, we had a conversation with folks who talked about the fact that when you're collecting information on race and ethnicity, it's not the same as it was in the past. And you have several different ways of capturing that information, and you can actually run into some issues with respect to how individuals actually feel comfortable recording that information and what that information adequately described. So the next question is, looking at what you've highlighted already, what are some of the additional strategies that you think that you're able to use, especially in the enhancement of information systems, to enhance data quality, including that of the completeness of key demographic information that's going to drive our decision making?
This is Jim, and maybe I'll start with a response. And I think everyone's laid out the problem very, very clearly of how difficult it is to get complete data in a lot of these situations, because as the public health department, we don't really have control of the data system collections that are being used for vaccine administration. And in many, many cases, we're relying on the data to be collected by the partners that are out there administering the vaccine and then sending them on to the health departments. So one of the things that we've done for some of our customers is to kind of rethink the business process and how we can help address that and try to collect some of that data up front in a pre-registration process. So try to put into place a pre-registration process that covers more of the vaccine administration across the different partners, that collects the information that you really need to make sure that you're getting that may not be collected by the people administering the vaccine. And then that can be linked up together, later, as other people have talked about how they've been linking different data sets so that you've got a more complete data set.
Yeah, I just wanted to kind of talk a little bit about what we've done to improve our data, but it certainly has lots of ways to go. One of the challenges that kind of remains is that we're matching our data that's coming from our immunizations information system to other data sources that have similar challenges. So a lot of times whenever we look at trying to fill in the gaps, we're filling in the gaps with other similar gaps. And the biggest hurdle we face is that we have so many data sets that we could use, but it's really hard to understand which one actually has the best information. So we come across a lot of discordant records where in one record, someone is identified as, such and such race or ethnicity, and in one record is identified as such and such. And, talking to the data stewards of, each of those, everyone claims that their data has this positivity or this robustness or these limitations, but it's really hard to reconcile that. And with the timelines that we're facing, and with the decisions that we want to make, a lot of these things are also at such a high speed turnaround. That is presenting a very unique challenge. I think in terms of a longer term evaluation, I think there needs to be, one of the things I'm really grateful for our department is that we're really working on a more robust person index and being able to have a lot of our data systems already connected, and hopefully next time prior to a global pandemic. But there needs to be a better way to evaluate how to address discordant records across different data systems that are being used, because it's not always helping in terms of filling in the gaps, because I don't necessarily feel confident in presenting to our public or our council or our leadership or government or whoever, saying that we filled in the gaps, but we filled it in with maybe potentially incorrect, or we just added a little bit more messiness to it. So I would be curious to see if people have had a better success in that, but that's been one of the largest challenges, because you can add data into things, but whether you're adding, whether that's accurate or not is really questionable. And with IIS, I feel like the biggest challenge has been this change in how people self-identify. I speak from my own kind of growing up and journey. I think there's been a lot of different ways that I have identified in terms of my own check boxes, and then as well as how nationally people have approached this question of what does race and ethnicity mean, and how people should be proud to label themselves or not label themselves in specific ways. And I think we also really underappreciate in public health and account for multiracial individuals. And when we look at our county, we have about 10% of individuals through the latest census, which is 2010. So we're based off estimates from a decade ago at this point, but 10% identified as multiracial at that point. And we're growing in terms of number of individuals that identify as multiracial, and how those individuals are being considered in terms of any sort of analysis nationally, or for any sort of sorts, is going to become a much larger topic over the next decades or so. But no clear solution, just adding more problems, or more things to consider, I guess.
Yeah, that fits exactly with what we're experiencing in Louisiana. The challenges, particularly to the demographic information with vaccine administrations, are really multifactorial, and some of them get very technical in nature and deal with the transfer of data and how data gets pulled on the back end of these programs. And the fixes are not easy. The fixes take time. So the temporizing solution has been to reconcile our data with existing databases, which, as you point out, I mean, this is a Band-Aid. It has its own problems, has its own shortcomings, but it's kind of a stopgap for us until we can fix kind of the root issues with our data systems and what's happening on the providers end, and get into what we can do to help more vaccine recipients feel comfortable sharing, checking the box or giving the race, explaining why we think that's important and what we're going to do with the information, how we're going to use it, and what type of decisions we hope to drive with it.
Any additional comments on this topic? Okay, moving on. One of the next questions actually comes from our pre-registered Sahira out of Texas. The question goes as follows. Ensuring equitable vaccine implementation requires good, reliable data for analysis. What are some strategies to assess and monitor data on vaccine distribution and administration to ensure that communities at highest risk are actually being served?
I guess I could jump in with some of the examples that we've been using. I think in testament to all the challenges described about demographic information, a lot of analysis depends on good data and confidence in the data that you're using. But we're also in a situation where we have to make decisions based on the best available thing that we have. So there are some certainly limitations that need to just be really upfront with whoever is going to be using any sort of analytical tool to either ensure where vaccination pop-ups or clinics are going to be placed or anything else. But one of the ways that we are really trying to monitor data quality is by doing these provider-based reports, looking at if there are places that are reporting more missing of either address, age groups, race, or ethnicity, and touching base with those individuals or those providers to see if they could improve their reporting. And then we also have, we have some things publicly available on our dashboard that show uptake by various different categories, including intersectional categories of race, ethnicity, age, location. And we have a more internal kind of working document that's really not super internal. It goes to all of our providers and vaccine distributors that looks at each zip code within the county, and we have about 90 zip codes or so. And for them to be able to look at, cumulative vaccine coverage by every single facet that we're interested in, which is currently, race, ethnicity, different age groups, healthcare worker status, or any sort of eligibility criteria based on occupation that we have within any zip code, and how that compares to other groups within that zip code. So we, with most of our community health clinics and other folks that are have a great relationship with either a geographic region or specific communities within that geography, we also look at it from our respect to be able to understand, like, can we allocate more doses to those places because they're able to actually reach the populations that we're seeing are falling behind other populations, even within a specific, neighborhood. And I think the speed of it is one of the biggest challenges, because I think some of the data is there, but getting things turned around is the largest struggle. And particularly when we look at how allocations and administration is going nationally, it's hard to not fall behind in terms of trying to address a lot of these issues, while other places may be moving towards opening up to larger populations and larger bodies of work. And then there's the pressures of, do we open up to a larger eligibility criteria while we know that certain communities or certain folks that are eligible already or have been eligible for, over a month are at half of the coverage compared to our other residents. So I think that analytic tools are there, but I'm also, speaking from the analysis position that I hold. But I think that, a lot of the operational stuff are extremely challenging.
So I would opine that Sarkis is exactly, on target in terms of his response. It aligns with the same thinking I was having with the question and the dialogue that we've had overall in terms of, we're focused on how we can use technology to better enable the use of data, all to help inform our vaccine implementation plans. And my hope would be that plans that are ensuring equitable access and subsequently uptake of the vaccine. What invariably tends to be happening in some of these communities, of course, we can focus on how do we have better data quality, both for who's signing up for the vaccine and who's ultimately getting vaccinated. But you have to question and challenge why you are seeing disparities in those two numbers. And it's not something that is manipulated through the technology itself or the data systems itself. It informs the program approach that you are using, right? So how then do you do additional things? So just manipulating the technology and making the technology more efficient and better doesn't eliminate the underlying causes and challenges or problems of an equitable vaccine program. Very practically speaking, if you're continuing to see that certain neighborhoods don't access the vaccine as well as other neighborhoods, or certain racial and ethnic groups are not accessing the vaccine at the same rates as others, you have to ask yourself, is this about access to the technology that helps them to register for appointments? Is this about access to the vaccination clinic locations? Or are these the key drivers that drive health and health decision-making overall that are absent anything to do with the technology? And you may see that. So with our priority zip code program, we have, we have vaccines that become available, appointments that become available, and they don't last for very long. They last longer when they're in our communities with the highest burden of disease that happen to be Brown and Latinx communities, right? And then there are times when we're making a decision about moving to another phase, we see a lower uptake from the communities, our Black and Brown communities, that suggest to us that we've probably gotten all of the early adopters of the vaccine that we're going to get in these communities, and there's still very high demand in citywide, right, in our communities that have lower disease burden in our non-Black and Brown communities. So that belies a greater issue and discussion around vaccine confidence and vaccine hesitancy that manipulating the technology and the data doesn't fix. So I'm always very cautious in these conversations about, Black and Brown communities, they're not going to use the websites, they're not going to use such and such, and that being the reason why they're not accessing vaccines, but we will be able to use that as an excuse into perpetuity as to why we're not supplementing it with using community-based organizations, knocking on doors, signing them up at their door, going and doing on-site vaccine clinics that require no pre-registration, all of those types of things that may help to get them access, eliminating other barriers to access to healthcare, as well as being able to have a series of town halls and discussions with them that answer any questions that they may have because of their lack of trust in government institutions and healthcare infrastructure. So that I think we need to make space for in some of these conversations. I know this particular town hall isn't it, but we'll exhaust our time with the 30 minutes we have remaining trying to pin a technology and data reason on some of the other problems that need to be solved.
I just have to chime in to Dr. Nesbitt points. There's such important points that I think, leaving out some of the digital tools that could potentially address this, even though we're talking about data analytics, I think we should spend a moment talking about them. And, Dr. Nesbitt talked about the call centers that are used in DC. So the people who may not be able to access a website can call in and register and schedule their vaccinations. But the way that AWS call centers actually work, they can actually be, I'll use an immunization term, bidirectional. And we're actually working on a really exciting project to try to get to bring together community-based organizations, exactly like Dr. Nesbitt was talking about, with their local health departments, to give those community-based organizations the digital tools that they need to reach out to their stakeholders better. So they could take advantage of those tools that could do some of the automated texting, do some of the automated calling, and have a place for the community-based organizations to keep track of their membership and reach out to them and use that tool to really make sure that their membership has their concerns addressed and are willing to get vaccines. So it's not exactly the data part that we were discussing, but I think it is a really critical part of the conversation when we talk about vaccine hesitancy and confidence.
And it underscores the issue that we have all mentioned, whether it's the social determinants of health or how do we embrace technology. There's the human interface side of our engagement, the public health side, of the public side of the public health, that devoid of whether it's a computer tool or a tablet or technology, that we have to really look at those underlying factors and see how they have uptaken more significantly the addressing of those points to really drive at our solutions if we're truly trying to identify those solutions. So thank you for that dose of reality, Dr. Nesbitt, and all to this particular question. If I can move to another question that did come in. And it's interesting because you think about all of the newfound technologies, and as we recognize, there's these public-private partnerships. There are groups that I sometimes call, there's a void, and we've heard all this kind of stuff. So let's just create something new. So a lot has been said about online vaccination registration systems. Let us discuss a bit more about what effective approaches are necessary to optimize accessibility, ease of use, security, and reliability of
opportunity there. We've not in Louisiana gone to a unified statewide system. We're about to bring on a system for the state-operated sites. We were using an older system that is proving inadequate. So we'll change that up for the sites that the state operates. We've not gone to one unified system for all vaccine providers across the state. We talked about it for sure. Listening to other state health officers around the country about their experiences, I think at this point, it's a mixed bag. I think there's some pros and cons on both sides of it. One of the features of the Louisiana vaccine rollout has been a very broad and wide disbursement of vaccine. So we've employed a lot of small clinics, a lot of independent pharmacies, a lot of essentially mom and pop operations. And there are some challenges if you try and get small entities like that, independent entities, to plug into one unified system. Not to say it can't be done. It's just a challenge. One of the experiences that has been relayed from other states that have done it is you do have a lot of liability when things don't go right. And when the system goes down, when it crashes because too many people log in trying to get vaccine, it goes down everywhere. And you end up with a couple of days where you can't really administer or log vaccine across the state. That said, I think in places where it's done well, it is a real tool. It simplifies things. It gets you data brought in, and I think it's probably where we're headed. But you can't jump into this too quickly because it does put you at considerable liability if the tech side doesn't work the way that it's built. I will say one of the things that's at the forefront of our mind, and it's so nice to hear Dr. Nesbitt talk about how DC has approached this. It's really valuable what you all have done, but you really got to be cognizant that the digital divide doesn't exacerbate your inequities that already exist with vaccine rollout. So anything that has an online portal has to have a way for people who don't want to access it or can't access it or unable to access it online to take part. So call centers, I think, are a phenomenal idea. Case managers, community health workers that can help enroll people have to be cognizant that you can't just rely on the online thing. And again, we should know all of these, I think, are somewhat temporizing because the end stage of this, hopefully is integrating vaccine into a more normal supply chain, which, clearly is months and months down the road, but
and this is Jim, and I think Dr. Cantor's points about it being really difficult to have a unified system are definitely the lessons that I think we've learned across many different states. And and it's challenging because we have pharmacies, small providers, just employers soon all giving vaccine, and it's tough to force your systems on them. And I think really what we need to make it easier for the consumer is to put some navigation tools in front of that to help direct the consumer to the right place. I think we're all doing the right thing right now with the call centers because, with the focus on senior citizens, I think high touch concierge level call centers are definitely the right way to go. But as we start opening it up to other populations who will expect to be able to do things on the web, that they're still going to be very frustrated with the sites that are out there. And I think one of the things that we can do, as opposed to trying to rip and replace, everything that exists with a single unified system, which, as you said, is a big challenge, we can put some tools in front of them to help navigate people to the right places. Right now, one of the big challenges is just trying to figure out what is the most appropriate place for me to schedule a vaccine. Should I go to a pharmacy? Should I go to my private provider because they're only vaccinating their patients, and that might be a good option for me? Or should I try to go to a public health clinic that's being run at a baseball park or something like that? But really having some kind of navigation tools in front of the registration that help guide people. I think that's the way to go as we start moving into phase 2 with a more tech savvy population. The call center functions that we've talked about earlier are not just traditional call centers. There are things that we can put into place to help people navigate using things like multimodal call centers, we call them. So we can have chatbots, voice recognition, a lot of different ways for people to interact to help direct them to the right place. And then I think ultimately what would be amazing would be if all of the different providers that are actually offering vaccine could actually have open that the states and local health departments could bring all of the relevant providers into a single site. You could see what vaccines are available and schedule all from a single place, just like you book a plane ticket today.
Yeah, and Jim ended exactly where I hoped he would, because one of the things with the phased approach is how do we leverage technology to build upon each new phase as it rolls in, recognizing that certain jurisdictions who have pre-registration processes or registration processes have people who are in queue for a vaccine. And when you start a new phase or you introduce a new provider who has its own tool and its own system, it's an opportunity for them to start at patient number 1 or client number 1, where some other list exists someplace else that has client number 7,000 on it, right? And that client number 7,000 doesn't get the opportunity to be client number 1 with this new provider who could give them vaccine access right away. And so one of the problems that states are trying to solve with having all of their providers using separate scheduling systems, not having an API, if you're not going to integrate all into one uniform scheduling system without APIs, what is the workaround? And so this concept of having an API where anybody on any list, every time a new provider is added, getting new vaccine supply, either directly from the federal government or from the state allocation, they're all being drawn from this same list of people in that jurisdiction who were already previously eligible under initial phases or in the new phase. And I think that gives some sense of fairness to the residents of that jurisdiction. And it kind of holds the executive, whether it be the governor, the mayor, the county executive, out of having to adjudicate why people are being, this appearance of being given preference to access for months.
Yeah, I very much agree with everything that people said. I just wanted to kind of highlight a couple of things that we have been in the process of selecting vendors and thinking about other vendors, mostly from private organizations that have either reached out to us, good partners, for other registration processes, particularly our testing partnerships. One of the, I would love to have a uniform system, but I think even just within our county, which might be, it's relatively small in the grand scheme of things. We are I think the 12th biggest county, but when we look at having a statewide uniformity, that seems like a dream to me. But if it's possible, that'd be great. But I think one of the really big struggles that we have and that we've had through our either closed pods or our mass vaccination sites, things that we have a little bit more control over, are one is language and prioritization, and people being able to register is massive, and I think people have touched upon a couple of it. But having systems that allow people to not just book a time, but there is a prioritization mechanism for that appointment setting, so that individuals are not just selecting a time based on the fact that they were able to get there first. And we've had a lot of struggles with building in that kind of infrastructure with any registration portal, where something goes live, and even if you only provide a link to a certain person, but it's live, and anyone with that link could kind of register, and it fills up very quickly. Some of the other things that we've had are also challenges with second dose appointments being scheduled, and working with systems, and we've been able to work a little bit with appending some of the ways that we've functioned on having second dose appointments scheduled at the same time or during their kind of observation periods. And that has really helped in terms of having accountability and having schedules set up. But one of the major data management things that I just want to make sure is acknowledged is integration with IIS is absolutely essential for any of these registration processes. It is probably one of the most time-intensive thing to have to double enter that into IIS. As the main analyst for our department, it's also been the largest painstake of hearing people say that they've registered these many people, but then in IIS only certain people are entered, and they're a week behind in data entry. From one system to another, when there are clear ways for systems to be developed, and many systems are developed to integrate the data between immunization registries as well as registration portals. And those things have, from the short experience, and I think we'll hopefully have opportunities to do more thorough evaluations throughout the year, it definitely helps. One, it frees up resources of people that can make phone calls or other follow-up things instead of data entry administration tasks, but also helps with all sorts of data quality issues.
You bring up an interesting point, Sargis, and I think going into the next participant question, Carrie from Florida asked, how can and will existing health information exchange, HIE infrastructures be leveraged to support vaccination efforts by public health? What do we see down the line as far as that's concerned?
I'll say one way. I want to broaden the net of interested parties that are helping out with this. I mean, right now we're really only using our HIE to help reconcile some of the demographic data. But down the road, I think we need to be getting our MCOs, getting insurers, getting payers, all in the game and all working to help connect their patients and clients or enrolled lives with access to vaccine, promotion, education, information. I think we, at least on behalf of the health department, we've gotten in a trap of thinking that it's our job, and no one else, and that we ain't gonna be able to do it. So I think we need to be really humble and knowing that we need a lot of help. I mean, we've gotten to a good place of engaging community-based organizations and people that are more grassroots, but there's other help out there as well. I mean, there's big-time insurers, I think, have a big role to play in this that we haven't really leveraged yet. I think the HIE would be a good way to connect with that.
Anyone else?
Smaller, but at the time equally, well, also stressful outbreaks have happened. Nothing compared to this one yet, but it would be really great for us to move towards much better integration of all of our communicable disease reporting, our IIS with just electronic lab reporting and electronic medical records. We spend so many resources, mostly fax. Now I'm thankful that we have electronic faxing. So it's still fax, but at least it comes in an email. But all of these valuable data elements are in, what used to be paper, now is a PDF, because physicians, EDs, they collect all this information. And we've been very successful in getting more and more information into our syndromic surveillance systems, getting more people onboarded onto those. But it's not as rich as a lot of the records and data that is kept in these electronic medical records. And having much better communication and having clear data sharing agreements, clear uses for those things will help so much, because we've had lots of questions about equity for other things outside of race, ethnicity. And these are data points that there's no way registration systems or IIS is ever gonna reach or gonna ask for, whether it's disability or LGBTQ status or any other sort of demographic or structural societal thing that people want to be able to measure and have, maybe some anecdotal or maybe some actual real examples of it. We cannot do those kind of things, but there are other data sources that do have that. There's rich data in the medical records that are not well integrated. But I think
to use the vaccination rates or the vaccination data that we've been collecting, combined with other metrics, I should say, in a dashboard to help inform decision about mitigation strategies, or are we there yet?
So this is Jen.
Yeah.
Oh.
Go ahead, Jim.
Okay. So I think we may not be there yet. I think there are examples to look at, though, in the earlier phases of COVID response, bringing together data from disparate data sets into health data lakes to really put all of that together, looking at testing and disease surveillance information combined with payer data. I don't think we've gotten there with immunization data, but it's going to be so important, because I can just imagine a few months from now, when hopefully, we have a much greater number of our population vaccinated, the first questions that we're going to start asking with contact tracing is, okay, have these contacts been vaccinated or not? And we're not going to have those linkages there, and that's going to be so critical. Or looking at incident cases in a post-vaccination world, have those people been vaccinated? Or are those ones that we need to prioritize for sequencing? There's so much that's going to be happening in the next few months that makes this critical, that I do think it's really important that we start thinking about how to bring immunization data into some of those data lakes that already exist.
I would say that, we've already started reporting on our dashboard vaccination coverage of our population. And as many of you are probably experiencing in your jurisdictions, because this country is in a deceleration phase with the pandemic in terms of downward trends for daily cases or daily reported cases, I should say, and hospitalizations due to COVID, and in most jurisdictions, daily reported deaths related to COVID, there's a huge interest And so much of that conversation is because people are seeing an increase in the number of doses administered. there's a difference in terms of having doses administered and having people fully vaccinated, which is vaccination coverage. And I do believe that there is an opportunity for the public health community, public health officials, and public health leaders to begin to communicate about vaccination coverage, and that it's vaccination coverage that we're trying to achieve and not just the number of doses administered in any particular jurisdiction. And when you juxtapose that against the other metrics that you have, and people's, belief that the arrival of the vaccine is sufficient to get back to normal pre-pandemic level activities, it can temper some of those expectations if those are the types of mitigation strategies that you're talking about. So we haven't gotten to a place where there's a good enough proportion of anyone being vaccinated or having induced immunity. We could, of course, have separate conversations about the susceptible population when you combine both natural infection and induced immunity. But I think it can go a long way in some communities to really have people be aware of the population that is fully vaccinated and where your coverage rates are compared to the number of doses administered versus doses you've received from the federal government.
Yeah, totally agree. It's a really exciting conversation to have, much more exciting than some of the other conversations that have been a part of the past few weeks. And look, we've just now gotten here. We're counting doses administered, for the first month and a half or so, and then finally able to really look at percent covered, as Dr. Nesbitt said. I think the CDC actually made the change on the CDC data tracker like last night, late last night. You can go on now and look at state by state. It'll show you some percentage coverage, some measure of that. So that's an exciting place to be. There are, I will say, our mitigation measures on the first half of this pandemic were not terribly sophisticated because there was no database really to build on. We were learning a lot. We still have a lot to learn, and part of this is going to be what we learn about your risk of transmission after getting vaccinated, which we think is looking better and better with the Israel data, but still there's a lot to learn about that. I think we'll be able to get much more sophisticated in how we approach mitigation measures, how we respond to rebounds when we inevitably do have rebounds of cases. I do want to flag, I think there's a big communities that have less percent coverage by virtue of urban mistrust and other barriers is going to have to be something that we put a lot of thought into. But that's a good conversation for us to be at right now.
Thank you. I'm going to go into kind of what we call our rapid fire, final question to all of our speakers. And thank you so much for this engaging conversation. Whether we look at it as an innovation that you're exploring or the experience that you've had, what has been your biggest lesson learned about managing COVID-19 vaccine data?
I'll start. I think it's the lesson that I've learned is don't hide your problems. Put them out front and center. Whatever your deficiencies are, they are likely solvable. Trust your engineers. Put them out there. Make sure everyone knows it and sees it. Don't bury your deficiencies around from data. That's the only way to approach it. A colleague of mine remarked yesterday, a very astute point. You got two events this past week, which juxtaposed. You've got the weather disaster in Texas with all the power outages, which clearly was the result of decades and decades of not listening to expert advice on what mitigating factors could work. And then you've got the Mars rover, which was a wild success and a result of many, many years of hard work and not avoiding tough issues and problems that I'm sure arose. So, we're better than taking the shortcut. So don't hide your problems, put them out there. They're likely solvable.
Yeah, so I would add that, we've come into this with a continuous quality improvement lens from our data perspective. And we've been transparent with all of our key stakeholders that that's the approach that we are taking. And so the systems that we implemented initially are not the systems that will end the pandemic with. We will have newer and improved technology solutions and systems because we'll take the feedback that we get from the public in terms of their user experience, and we'll improve them in terms of their functionality for us. Because long-term, we should be looking at these as their potential to be legacy tools that can be used to support core public health functions long-term, and not just something that helps us manage a pandemic. So for us, it's just always about continuous quality improvement and being flexible. So my biggest lesson is just, really reinforcing that and using that as a guiding principle, but also elevating that as a key point with all of our stakeholder engagement. Be ready to, I think we've stopped saying pivot, but it's been around like a top with us as we implement the vaccine plan.
And this is Jim, and I think one of the things Dr. Cantor said is really important, and I think a lesson that we should remember, we can't do this alone, and we being public health. And I think, knowing that there are partners out there like the payer community, schools, employers, private sector that really want to work with public health and have the same goals, that's critical. And make sure that you're taking advantage of those partnerships. And I think the other really important lesson that I've learned is, don't think just about what's happening today, what's going to be happening 3 months from now, because we've got to, whatever's going to be happening 3 months from now, we've got to start building for that. We don't want to be in the position where we're trying to build something at the same time it's needed. So make sure that we're thinking 2 to 3 months ahead, because when we start thinking about data systems and digital tools, there's always a lead time to getting those in place. And we want to make sure that we're looking at what's coming at us in the next couple of months.
If we just quickly go with echoing a lot of what everyone said, flexibility in everything, and mentally and work-wise has been probably the biggest lesson learned. But timeliness, as well as making sure that the folks that you want to understand the data understand it, and building really good, easy to read documents, both for people that are primary consumers of the information, but also people that kind of depend on other people to describe the information. So it's mostly just been about having really good partnerships of folks that are trusted within communities that understand the information that you are sharing and understand the limitations, so that they could be better voices. And I'm not going to be able to translate every single thing into the 20 some odd languages that we desire to translate into. But if we are able to host weekly meetings with folks that are trusted within those communities and make sure that they understand the information and are able to then disseminate that, that's been one of the biggest lessons learned, is rely on the community engagement that exists and build better ones if they don't exist. But yeah, that's probably been the biggest lessons learned.
Thank you all so much. It is a humble opportunity to be with all of you this evening, or today, I should say, and really participate in this important town hall. I would like to underscore some of the key takeaways that we did hear in the course of our dialogue today. And they're very important to that extent. We recognize that we need to identify and implement enhancements to the IT systems and other solutions to ensure that we have scalability and that we can augment data collection and inform effective and equitable vaccine implementation. I'm going to take moderator's privilege and actually add another key takeaway that was very much underscored by Dr. Nesbitt. We need to recognize that there are non-tech barriers that will need to be addressed in order to improve the issues of equity, access, and utilization. Then we need to assess and improve data quality, ensure that data are available, reliable, secure, complete, timely, valid, accurate, and not duplicated. And we need to identify key operational needs and build flexibility into our registration platforms to ensure that they have multiple uses and can be adapted as much as needed for future sustainability. We need to maintain public-facing data dashboards that can provide transparent communication of vaccine distribution and administrative data and metrics by geography, demographics, including that of race and ethnicity. Also, we need to enhance public and private sector partnerships, including immunization, as well as public health emergency preparedness programs, emergency management agencies, healthcare organizations, industry groups that include critical infrastructure sectors, policymakers, and community vaccination providers in order to ensure that necessary data are reliably available to public health policymakers and those same providers. And then we need to consider sustainability and future needs beyond COVID-19 when we're making decisions about data infrastructure enhancement. So with that, we thank you so much for your time and your efforts today. For all the participants, I will point you to the discussion boards that is available for you to share more information amongst each other, and also to look at the Learning Center for resources where more details are available in the chat. There will be a CDC expert available to answer questions for about an hour following the close of this important town hall session. And with that, my colleagues in public health and on this particular panel, I thank you and thank you and thank you. Have a blessed day.